Hi, good evening to everyone. Thank you very much for joining us on this Thursday evening before Christmas as we talk about the COVID pandemic and look at some of the issues that are coming up. Now, as usual, I've had a tremendous pleasure since March 2021 to speak with Geert Vanden Bossche. I'm proud to say that I was the very first person to interview him. And I've interviewed him on a number of occasions all through that time. I've interviewed him with Robert Malone, I've interviewed him with Dr. Shetty, and every time that I've interviewed him, he brings more to the table. So I feel very privileged to listen to him. And even though we talk live, I get the opportunity to ask him questions pre and post that really allows one to dig into his thinking and why it is that he speaks about what he does. So without further ado, I'll straight away bring Gert in. And hi, Gert, how are you doing?
Hi, Philip. I've since this is a formality, I guess I will say I'm doing fine, but in fact, that is not completely true. I feel
Excellent.
very, very concerned.
Yes, I know the feeling, Gert, because I have that anxious feeling. And I keep on saying to people, I'm more worried now at this stage of the pandemic than I was even at the very beginning. And I was worried at the beginning of the pandemic. But just in case any of our viewers have never met you before, do you mind just going over simply who are you and why are you speaking?
I will start with my background. I have a background in veterinary medicine. And I specialized in virology and molecular biology, immunology. That was a long time ago at the University of Berlin, the Robert Koch Institute. And I also specialized in environmental virology, microbiology, and from there, I moved on to the vaccine industry, where I worked as well in early development as in late development. I was responsible for adjuvant development, especially working in the preclinical department. So worked with three big vaccine companies. And then I moved on to work with global health, first with the Bill and Melinda Gates Foundation as the program manager, program officer in vaccine discovery, and later on with GAVI, the Global Alliance for Vaccines and Immunization, where I worked as the program manager for the Ebola program. And besides that, I've been doing my own research on NK cell and natural killer cell based vaccines. So I was very much interested in vaccines, of course, but essentially vaccines for tackling global problems, not personalized medicine, but vaccines that could help many people on the globe. So when I saw then that the purpose of the vaccine against SARS-CoV-2 was to do mass vaccination after the pandemic had already started, I knew that this was going to have exactly the opposite effect of benefiting people on the globe. So I knew from the very beginning that there was nothing so predictable than the detrimental, the disastrous consequences that mass vaccination in the middle of a pandemic would have. And therefore, I've continued raising my voice and ringing the alarm bell and sharing my thoughts, warning people, raising awareness, you name it. Over.
Gert, I still question about the fact that you are one of those lone voices. And this is one of the issues is that people, critics of you could say, well, if this was an issue, more people, more scientists would get on board and support what you're doing and what you're saying. But we've not really seen that. and people struggle to understand why, if this is accurate, would so many scientists just stay silent?
Mm. Yeah, well, I'm not at all, I feel not at all impressed by this. We have seen this in the past. Major companies, major organizations, including the WHO, just completely doing the right thing while the wrong thing, sorry, completely the wrong thing, while censoring critical voices like myself and others. I give you just a few examples where people like me were absolute exceptions who nevertheless proved to be right. This was, for example, the polio vaccination, where while I was with the Bill and Melinda Gates Foundation, I told them their policy would lead to a disastrous development of the polio virus. And that is what we are facing right now. And all these vaccination campaigns are now driving poliovirus, vaccine-derived poliovirus, to more virulent forms. We have seen the same, which experienced as well with the Ebola program 8-9 years ago in West Africa, where basically under the auspices of the WHO, people have been vaccinated during the incubation time, because this was ring vaccination, which led to deaths, was a major mistake. Now we are seeing vaccination during a pandemic. We see the global program of the WHO, for example, driving for more extensive flu vaccination, which will simply enhance the next flu pandemic. All these type of things, all the masses, of course, the industry, they can benefit from this. Stupid decision makers at these global health organizations, of course, they are all vilifying us. They are all saying, well, this what they try to make people believe that critical voices like myself and others are completely wrong and that they are right. But we know the past has proven that in all cases, without any exception in the global health arena, it has been exactly the opposite, that the critical voices, the few exceptions, were right and that the mass was wrong, right? And so I'm not at all impressed with this and feeling isolated. I have the biggest and the best ally ever, which is the science, the truth, and nature. Over.
Yeah, I think those are powerful statements, Gert. But I think that science has been damaged in this period of time. And when you think about your own industry, because at the end of the day, even though you're a critical voice, you know the benefit of vaccines across the world. Was that a hard decision to challenge the industry, knowing that it was possible that people could then turn away generally from vaccines because of these errors that have been happening? Was that anything that would concern you?
Well, I mean, I was one of the first probably to say that, already 2 years ago, that the word vaccine would probably be banned from the medical vademecum because a lot of harm has been done and is being done. Um, with regard to my colleagues in the vaccine industry, I still think that those who are really responsible is the WHO, those decision makers, because don't forget, we know this. I knew this, everybody should know this. The business model of big pharma, including the vaccine industry, is to enrich the shareholders, right? They are not supposed my colleagues to take care of your health. They are supposed, to make vaccines that can be sold on the markets and bring a lot of money for the shareholders. So, yeah, no, it that for me was not an argument. And on top, if you see the consequences I'm talking about and the scale of the harm that is inflicted on people, these arguments don't even play for me, right?
I struggle to understand, Gert. I can understand critics at the early phase of what you said because they said to themselves, we're listening to other experts. Other experts say this is ridiculous. This is not going to happen. Get on with the vaccination program. But once there started to be a clear transition, especially with the arrival of, say, Omicron, I genuinely I'm flabbergasted that people still have that question at this stage. It's almost inconceivable. What's the explanation that even when it's blatantly obvious something isn't right, they still can't see it? What is that about?
Well, I think, and I try to be very kind and very gentle. I think that the major argument they still have is that the vaccines protect against severe disease, severe COVID-19 related disease. So I'm not talking here about all the side effects and the excess deaths that are unambiguously, directly or indirectly linked to the immune derailment caused by the vaccines. But they still have this argument, and what they are obviously not used to is that because, let's say, for an individual, just like with a drug, if you can treat somebody and prevent the disease, that is, so to say, great, or even to mitigate the disease. But here we are dealing with, let's say, a global health disease. And so it's absolutely mandatory if you want to fight a pandemic. If you think you would do that, or you could do this, is that you have to prevent infection, because otherwise you're just going to promote the transmission. And that has been the problem. So the argument, protection against disease, is completely invalid in a global health context, because if you can only protect against the disease but not against infection, you are going to make sure that the virus is spreading, that the virus is transmitted, and that people with imperfect protection, that is what protection against disease but not against infection does, that people with imperfect protection will, of course, breed variants, in a sense that they will give a natural advantage, a fitness advantage to mutants that happen, of course, to be generated all the time, but to those mutants that happen to be able to overcome this protection. And that is how, because of the mass vaccination, we turned a natural pandemic into an immune escape pandemic. And those guys don't seem to realize that this is now, since Omicron, a self-perpetuating cycle of immune escape variant generation, of immune escape variants. And as long as for an individual there is still protection against the disease, they will continue, because they are concerned, legitimately, of course, of their health system. They will advise, they will strongly recommend, they will advocate for continuing vaccination, because they don't realize that what is happening in the end, that the virus will become more virulent, and we will discuss this. And for me, the indices are very, very clear that this is going to happen, and that will then bombard the health system, the healthcare system. But this is in future. These guys don't look in the future. They look what's happening now. Same with our politicians, same with our public health authorities, and they don't look at the disastrous consequences that will impact very severely our healthcare system, our hospitals, etc. So it has to do, that is also what I put in my writings, with the short-sightedness of, unfortunately, including scientists. This is very unfortunate, but that is the argument that keeps these guys alive, I would say. The vaccine still protects against severe disease, and to some extent, one must say, also against disease altogether.
these are some critical points now, because I think one of the things that I've been saying, and you can correct me if I'm wrong, is that it seems that populations, highly vaccinated populations, are now in a spiral where no matter what, no matter almost, I think we've run out of options. We cannot stop the virus from circulating. And there will just be variant after variant after variant. Is that about correct?
It is about correct. It will be stopped. That is the only difference. This will not continue. But to your point, of course, what we discussed, if you cannot if you cannot stop the transmission of the virus, and we definitely cannot do this, we have not done this. First of all, you see, from a virological viewpoint, the virus, as you were pointing out, continues to evolve. As we can see from an immunological viewpoint, we don't get to this herd immunity, so we have no herd immunity whatsoever. From a clinical viewpoint, we continue to have breakthrough infections, symptoms, continuing a continuum of clinical manifestations ranging from asymptomatic asymptomatic infection all the way up to severe disease, in fact. So all parameters, whether they are immunological, virological, or clinical, are clearly indicating that we cannot and we are not controlling the virus. And that is where the virus will evolve to some point. And that is why I'm so worried now, because I clearly see that this is what is going on right now, will evolve to a point where it will put a brutal end to this. And I'm not, I'm not excited, I'm not happy, I'm not lucky to say this, but somebody must say this, right? That this is not going to continue forever. We have no herd immunity, we have no endemicity. Those who are pretending this are just, not understanding anything about epidemiology, about immunology whatsoever. This virus continues spreading. We have no control of it, and if you have no control, I mean, only the virus can end this. We have missed our last opportunity before Omicron arrived. We still had an opportunity to shift gears and to put an end to this. But since the advent of Omicron, what we have seen, as you pointed out, is a self-perpetuating cycle of vaccine breakthrough infections, one after the other, resulting in immune refocusing and continuous immune escape, right? So
This is frightening stuff, Gert. And as I said, it's very difficult, and I can imagine to predict timing. But I guess you're suggesting that at some point this is going to explode into something very, very serious. So one of the questions I'm thinking about is, when I think of the vaccine, and some people would argue, is it actually a vaccine, or is it behaving more like a therapeutic, meaning something that prevents severe disease but doesn't actually stop infection? Is it truly, in your vaccine expertise, a vaccine per se?
well, Philip, I can of course answer that question, but right now I am thinking in dimensions that go way above those questions, in a sense that what is the problem is that this stuff, whether you call it a vaccine, or you call it a therapeutic, or you call it, a GMO, or whatever, genetically modified organism, etc., gene therapy, whatever. The problem is that it has worked as a vaccine in a sense of inducing immune responses that, however, were not able to control the virus and therefore have caused immune escape in an, as I was saying, in a self-perpetuating way. So for me, this is not even a vaccine, but in terms of the definition, because you would never ever administer a vaccine where, first of all, you cannot control the dose. I mean, the spike protein is produced in the body of the transfected person, of the vaccinated person. So you cannot control the dose. This is unprecedented in vaccinology. You cannot control the location of, where the antigen is basically present, because it spreads, through the whole body, and you cannot control the duration of the expression of the protein. So already, due to these three criteria, this should be for every vaccinologist an absolute no-go, and it does not comply with any definition of vaccines, where normally you have a very well controlled dose. These things are biodegradable and disappear within just a few hours, or maximum maybe 1 or 2 days, and where that it stays at the injection site. So from the conservative requirements that a vaccine should comply with, this one doesn't comply with any of those requirements, regardless of the way it got manufactured, the way it got injected, the way but it's a consequence, of course, of the fact that you inject the code and then you leave it to the human cell, and that is the factory, to produce wherever it can, as long as it can, in a completely uncontrolled way. So from a definition viewpoint, no, for me it's not a vaccine, but practically speaking, it is generating immune responses against the antigen that is produced in the human cell. And those antigens that are, and the antibodies or the immune responses that are produced against the spike protein that is expressed at the surface of a transfected cell, the mRNA vaccines, in its own right, I've described it several times, is inducing immune refocusing, is inducing the wrong immune response. And that on top is a disaster in its own right, because as soon as you have immune refocusing, you are set up for an irreversible chain of immune escape. That is what immune refocusing does.
So brought me to a very important paper here that was published later, at about October of this year. And this was showing here the response of the neutralization response with regards to the bivalent booster. And if you can see it, you can see this is the original Wuhan variant, and this is BA.2.186. And essentially, what you're seeing here is that with bivalent booster at baseline, no bivalent booster, whichever way you take it, the strongest response, antibody response at every stage, no infection, with infection, has always been to the original variant. Is that what you mean about the immune refocusing? I know, just so people can understand, when we look at these numbers here, this is a logarithmic scale. So actually this here, even though it looks pretty close to this is 20,000 versus 400. Is this the is this representative of what it is you are saying, where you have an immune response that is so focused? So, in a sense, the vaccine worked, but too well. It's almost the equivalent of what could happen with dengue, where you have the original focusing on one variant. When you hit the second variant, the immune system can't shift. Is that similar?
No, it's not. It's not similar. It is so. Immune refocusing, I mean, it's a notion, a term that is well known in vaccinology, but I've never seen this phenomenon being produced, let's say, in a natural way. The way we vaccinologists try to refocus the immune response is by redesigning the antigen, right? Here, of course, the antigen has not been redesigned, but what happens, and I mean, I have a slide on this or a cartoon, but let me first explain. Immune refocusing happens, for example, when you have a vaccine breakthrough infection. So that means when you have neutralizing antibodies that are no longer have no longer sufficient capacity to neutralize the virus, then you are going to have a vaccine breakthrough infection. So what this vaccine breakthrough infection does is that it will tremendously boost these previously induced antibodies. And because you boost these antibodies, they will reach very high titers, and despite the fact that they have considerably lost their neutralizing capacity, at these exceptionally high titers caused by vaccine breakthrough infection, they can still, by saturation of the surface of the virus, they can still have some neutralizing effect, which, however, will be very, very short-lived. But during the time where they have this neutralizing effect, they bind to the dominant epitopes of the spike. And by doing that, the subdominant epitopes that normally are outcompeted by the dominant epitopes, they now can be recognized by the immune system, because the subdominant epitopes, per definition, they are less immunogenic, because they are more conserved. They will induce neutralizing antibodies that are now cross-neutralizing, because they are targeting more conserved parts of spike protein. So that is one thing. They induce cross-neutralizing antibodies. You could say, wow, this is fine, because these are all the publications that we see how after vaccine breakthrough infections, people develop antibodies that are now capable of neutralizing not just the circulating variant, but even other variants, SARS-CoV-2 variants. And secondarily, what is even more important is that when these antibodies, these newly primed antibodies, they start to lose their neutralizing capacity, they become sub-neutralizing. Sub-neutralizing means suboptimal. They start to exert suboptimal immune pressure on viral infectivity. And basically, by this phenomenon, they drive the propagation, the natural selection, the propagation of more infectious variants. So that the third thing is, to your question, that of course, because these antibodies have much lower affinity, they will have lower neutralizing titers. They are directed at less immunogenic epitopes. The advantage, they're cross-neutralizing. The disadvantage, they have low titers. They will very rapidly progress to suboptimal neutralization. And that suboptimal neutralization derives immune pressure. And in highly vaccinated populations, this collectively exerted immune pressure on the neutralizability of the virus will, of course, and that is what we have seen all the time, promote the natural selection and dominant propagation of more and more infectious variants. So now the thing is that the mRNA vaccines, I've explained this in my book, that they already induce antibodies of low affinity to the immunodominant epitopes. They, of course, also induce antibodies against, the dominant epitopes. But at the moment where they are still sitting on the surface of the transfected cell, at that moment, they can induce low affinity antibodies. That is not the case with natural infection, because once the virus comes out of the cell, there is no there is no prolonged expression of this spike on the surface of the infected cell. But here, the mRNA has been stabilized to be able, I would say, or to make sure that the spike protein that is expressed at the surface of the transfected cell before it gets released from the cell, that this is prolonged, and that induces imperfect, low affinity antibodies that will recognize the immunodominant epitopes and will automatically give priority to the subdominant epitopes. That is why, after the second dose of mRNA vaccines, we have seen cross-neutralizing antibodies against several different variants. And of course, the manufacturers and the WHO were saying, oh, wow, this is great. This is a great technology. Look, I mean, we are now even broadening the immune response. They've not taken into account that they were generating low affinity antibodies, and that is why the titers are low. That is what you're seeing with the mRNA vaccines, and that they would very rapidly evolve towards sub-neutralization, suboptimal titers that would only drive immune escape, right?
And so, yes,
yeah.
I've just pulled this back up again because, yes, what you're saying effectively. So, for the BA.2.86 variant, out of all of these antibodies that are being produced, only a small proportion is targeting the BA.2.16 in every single situation, even where it had infection. The primary change, look at that, it goes from 16,000 to 35,000. This goes from 300 to 900. So the primary immune response is for all the other variants that were occurring. This is pretty serious, Geert, because it suggests that this immune response is just not going to get better. This is one of the worries, is that when you look forward then, so let's extrapolate. What does this mean for populations realistically? Because this, I just can't see how this is going to stop.
Well, what this means is very, very easy, is that by administering these vaccines or even the booster doses, you are just going to accelerate the immune refocusing events. And by doing that, you're just going to accelerate the immune escape, right? So this effect, people should realize that what we are talking about here is not real neutralization. It is pseudo neutralization. Why I'm saying this? Well, it's in fact these antibodies, as I was pointing out, because they are directed at less immunogenic domains, they have low affinity. And we know that the behavior of low affinity antibodies, the binding of low affinity antibodies to the virus, is completely different from the binding of high affinity antibodies to the virus. High affinity antibodies are, for example, the IgGs. But the antibodies that are generated here, what we are talking about, are IgM antibodies. Remember, the immune refocusing is then for the first time priming an immune response against the subdominant domain. So you have IgM antibodies, which are, I'm sorry for the technical terms, but which are polyvalent. They have several different arms of antibodies. And now what we are seeing right now is a completely different interaction between the virus and the antibodies. Now we are talking about avidity, not affinity. Avidity is the property of an antibody to interact with several different sites on the virus. It's like, you can grasp a soccer ball, with one very strong hand at one side of the ball. But you can also grasp this ball with multiple hands with weaker forces. You can also grasp it, right? Multiple hands, but weak forces. Or one hand, this is the specificity, very specific and very strong. Or weak, but multiple arms. That is what the low affinity antibodies do. So in other terms, these low affinity antibodies can only interact with the virus or with the spike protein, listen, when it is presented as a multimeric structure. So the spike, everybody has seen these images of spike protein. There is multiple spikes on the surface of the virus. That is a multimeric distribution. The low affinity antibodies can only react with this multimeric presentation. They cannot react with the monovalent spike. And for God's sake, I mean, these scientists, I blame them. It's a shame. It's an insult to the science. They should have double-checked the activity of these antibodies using monovalent spike in an ELISA. When you use monovalent spike in an ELISA, none of these antibodies will react anymore. And that is how you can see that these antibodies are only pseudo-neutralizing. It's only when you use them at very, very high concentration, like after a vaccine breakthrough infection, that you will basically saturate the surface of the virus so that it can no longer dock on the susceptible cell, so it's neutralizing. But as soon as the concentration goes down, this effect is transformed no longer in inhibition of infection or neutralization, but in mitigation only of the infection. It will only dampen the infection. That means sub-neutralizing activity. That means that this prolonged activity, because these antibodies can stabilize the virus in form of aggregates for a longer time, and due to this prolonged suboptimal functional activity, it will tremendously drive immune escape, and it will drive large-scale immune escape because it is targeted at conserved epitopes on the virus. That is why we have seen the succession of more and more infectious variants that basically were sharing most of their mutations, because, of course, they were selected due to immune selection pressure on broadly conserved epitopes contained within spike. So I'm sorry, this is complex, but what they are showing is completely misleading. And thanks, Philippe, for putting up this slide. So what I'm explaining is that indeed, everything started, and that is not just me saying, Professor Fantini from Marseille, etc., has clearly shown that when you have antibodies that start to lose their neutralizing capacity, for example, when Omicron came, the antibodies that people were sitting on had a seriously diminished neutralizing capacity towards the virus. That is what you see on the left side of the cartoon, that these antibodies could have an infection enhancing effect. The enhancement of the infection is complex. How does that work? Well, I can explain this. These antibodies, they will no longer neutralize, of course, but they can still attach to the single virions, to the single particles, by a weak binding. That weak binding is poorly specific, but it can mask the immunogenic epitopes. So that means that non-immunogenic epitopes, completely conserved epitopes, will now be recognized by the immune system. Those will generate the famous non-neutralizing antibodies that documented in several peer-reviewed journals that have the capacity to attach to the very conserved antigenic site that was recognized thanks to the masking by these antibodies, that was now recognized and was not previously recognized by the immune system. We call these epitopes immunoquiescent or immunosilent. They are now recognized. They produce antibodies against this conserved antigenic site, which is located within the N-terminal domain of spike. And those antibodies, and this has been described in several publications, they will enhance, they will change the position of the spike protein so that it can now readily dock on the susceptible cell and enhance the infectiousness of the virus. So then when you have the vaccine breakthrough infection, you will now elicit very, very high titers of these poorly neutralizing antibodies. This is what you can see in A. And they will have momentarily just a short-lived neutralizing effect. And all these publications that are showing that high titers of these antibodies can neutralize several different variants, they all analyze sera within 2 weeks, for God's sake, after, for example, the boost, right? Because what I'm saying is that they are short-lived. And of course, the lower the concentration or the more time goes by, the less these antibodies will be able to stabilize single viral particles. They will now stabilize larger particles. And Philip, if you would please put up the third slide, I can show how this comes. This is easy to understand. The third one, yes. So here you have two viral particles. Let's say these antibodies have a high affinity. So you can see there is 2 times 6 antibodies that can recognize specific epitopes on this viral particle. So what is now happening when the affinity of the antibody is much lower? So this or less thick, so this represents a reduced affinity of the antibody. Well, normally, these low affinity antibodies, they cannot attach to the single viral particle. Why is this? Well, the low affinity means, in fact, or the binding of the antibodies is determined by the surface of the particle. So that means that the binding strength for low affinity, the binding strength for these low affinity antibodies per surface unit is too low. So I repeat, for the low affinity antibodies, they cannot bind like the high affinity antibodies, so 2 times 6, because the binding strength per surface unit of these low affinity antibodies is too low. So what can you do then? Well, you can make an aggregate. When you build an aggregate, you are going to reduce the surface. The circumference here is much smaller than the sum of the two circumferences of these two particles. Now these low affinity antibodies can bind and can stabilize this. So that means that low affinity antibodies, as the ones we have been talking about, the cross-variant reactive antibodies, are primarily stabilizing viral aggregates. And of course, the lower the affinity, because after every immune refocusing that follows the vaccine breakthrough infection, you are going to show new, less immunodominant domains to the immune system that will generate antibodies with less affinity. Less affinity means that these antibodies are now going to favor, to promote the stabilization of larger aggregates. And these larger aggregates will ultimately be readily taken up by antigen-presenting cells. That is what antigen-presenting cells love to do, is to pick up larger particles, and they will induce CTL responses. And from there, I can explain that this why the current evolution of JN.1 is so extremely worrisome. I don't know whether Philip wants first to interrupt me, but JN.1, let's first say this. JN.1 is not worrisome in its own right. And our public health authorities, very clever guys, are saying it's not more virulent than any other of these co-circulating variants. And they are right. But what these guys ignore is the message that JN.1 is bringing. And that message you can only understand when you analyze what is so specific about JN.1. When you understand this, you can go back to what has been the immune pressure that caused these mutations in JN.1. And once you have solved that question, you can then, of course, also predict what is going to happen next or what is already ongoing. And we can further elaborate on this. I'm sorry, this is complex, but right
So,
now,
mhm.
nobody, Philip, is understanding how it can be that we see the new mutants, they have escaped almost completely from the neutralizing antibodies. When you look at the neutralizing domains of spike, they have changed completely from what they originally were. And then somebody comes and says, you know what, these vaccines are still doing the job, and we still have plenty of neutralizing antibodies that can neutralize a multitude of newly emerging variants. So
I'm going.
something is suspicious there, and nobody clarifies this, right?
I'm going to show an image from that same paper showing the differences in terms of the multiple sites in red, where these are all new mutations on this spike protein. This is in different angles. This is absolutely frightening changes. It's like the virus is continuing to evolve. And I'll quickly show you here, Gert, just before you go on. There's another part of it that I found a fascinating image, is this one here, showing the different Omicron variants. This was BA2. So these here are all the changes that BA2 had on the spike protein. But when you compare BA2 to now BA2.86, so in red are all the new mutations on top of the gray ones and on top of the teal ones that is occurring. And this continuous evolution, because BA216 was just prior to the JN.1, so JN.1 came from BA2.86. It's ongoing. It just doesn't stop.
Yeah, well, yeah, and then you have all this, scientists, health experts saying, look at the data. Of course, they are not showing ELISA data. They are not showing the data after like 1 month. They are boosting, and then immediately 2 weeks thereafter, they say, oh wow, we have neutralizing antibodies. I'm telling you, this is reaction between low affinity antibodies and the virus. And you could say, I don't care, because if neutralizing, yeah, I agree. But this neutralizing effect, because it is, let's say, the result of interaction of low affinity antibodies, will rapidly result in interaction of these antibodies in a way that is no longer neutralizing, but that is simply dampening the infectiousness of the virus, which generates suboptimal immune pressure and drives immune escape. And that is not what you're saying. That is not, but if you would do ELISA, you could immediately see that these are not genuine neutralizing antibodies, because they have no specificity for the monovalent epitope. They can only interact with the multimeric presentation of the spike on a viral particle or on viral aggregates, etc. And that therefore their neutralizing effect is very much limited in time, in that it will ultimately, and that is what I'm saying, that is what JN.1 tells us. JN.1 is fine in its own right, but it tells us something which is extremely, extremely worrisome. And it tells us basically that we have, or, the highly vaccinated populations have in the meantime progressed, their antibodies to stabilizing aggregates that are now primarily taken up by antigen presenting cells, and are driving mitigation of infection, because even vaccinees who are regularly exposed, they have no severe symptoms. There are a few, of course, but the vast majority are regularly exposed, have still relatively mild symptoms. So that mitigation of the disease is now explained by the cytotoxic T cells that will abrogate the infection or abrogate or kill cells that have been infected already. And so they have been infected, and then these CTLs come in and they kill the infected cell. So that is another way of mitigating the infection, which is deriving, of course, more infectious variants like JN.1. But if one could say, yeah, this is just a theory. I mean, where is the proof? Well, the proof is here. What we are seeing, everybody can see this. These are just observations. What are the 4 things that we see right now? First of all, what we see is that JN.1 spreads like wildfire. It has outpaced all of the co-circulating variants globally in no time. So that is an observation, nobody can dispute this. Secondarily, what we see is that we are now seeing, still not dramatic, but we see a very clear surge in cases of hospitalization, severe disease, and death. That is also observed in several European countries, I think also in many states in the US. But now the most interesting thing, when you look at the changes of JN.1, if you look at the mutations, there is something extremely spectacular. For the first time, the mutations are no longer limited to conserved domains. Remember, the conserved domains are those that are shared among several different variants. So people have been documenting this, that the mutations seen in JN.1, there is now mutations popping up that are very uncommon, that are pretty exceptional, that are pretty rare, that are not part of the commonly observed mutations that we used to see with previous dominant variants. And then, interestingly enough, we are now also seeing a number of mutations that aren't even spike specific anymore. They are located in other viral proteins. And these mutations, they all have an infection enhancing effect. That means the mutations in those other proteins than spike, they are, for example, promoting the efficiency of viral protein synthesis, or they are promoting the efficacy of intracellular viral replication. And so, in other words, even if at this point you are not saying this is due to immune pressure by CTL responses, you have to conclude that JN.1, unless you think like some conspiracy theories that this is yet another virus that has been fabricated, I don't know, by Klaus Schwab and maybe Bill Gates somewhere in the middle of nowhere in the desert in their private lab. But what I see is that JN.1 is the result of immune pressure on the virus, an immune pressure that, first of all, is no longer, or that moved away very clearly from targeting common epitopes. It moved away from targeting epitopes that are shared among several different variants. That is one thing. And it moved even away from targeting epitopes that are within spike. So when you look at this is very, very interesting, because all the infection mitigating antibodies that we were talking about just a while ago, they still were more or less specific, and they were still directed against spike protein. So now you can imagine, if you pull both things together, the observations and what I just explained in the graph that you, Philip, showed on how the newly synthesized antibodies tend to promote the stabilization of larger viral aggregates that are taken up by antigen-presenting cells. If they stimulate CTLs, and these CTLs, they are directed against the universal epitope. You can show this, Philip, maybe in slide 1 for the scientists who are watching. This is published, I think, 12 or 15 years ago, how you can see that all the coronaviruses are sharing a universal epitope. This is an epitope that binds to the antigen-presenting molecules regardless of their genetic haplotype. It has very, very strong binding, and it induces CTL responses that aren't even specific for spike. It's not because the epitope here is located within spike that the CTLs that are induced are exclusive or can only recognize spike. It's a universal epitope. So that can bind very, very strongly. And so we see that, the immune refocusing theory is telling us that we are arriving, or we would be ultimately arriving at a stage where the CTLs are taking over in terms of mitigating the infection. But then I'm saying, wait a minute, if that is the case, we would still expect that the infection is, or that the immune response by the CTLs is exerting suboptimal immune pressure on viral infectiousness, because it is, it cannot prevent the infection. The CTLs cannot prevent the infection. They could prevent the infection if they would have memory. But I'm still waiting, from all these guys who are pretending the T cells are important. I'm still waiting for any publication that shows that either by natural infection or by the vaccine, there are memory CTLs involved. It's not the case. These CTLs are not memory, and therefore they can only interact once the cell is already infected, and therefore it will only mitigate but not prevent the infection. So that already explains why we have now again a variant that is more infectious, but the mutations, interestingly enough, as I was saying, they are directed against the universal epitope, so to say, or the infection mitigating effect. The universal epitope is not selective, right? So it's not selecting mutations that are specific for spike, for example, and even the mutations within spike are not shared amongst the variants. When you put all these things together, you can now clearly confirm that JN.1, although it is not virulent in its own right, I fully agree, but it tells us something. What it tells us is that we have been shifting the immune focusing from the humoral responses now to a cellular response. And if you show, Philip, just slide 2, the immune refocusing, I've shown this several different times, is due to the fact, as I explained before, that antibodies with low neutralizing capacity will still bind to the immunodominant epitopes. And so it makes subdominant epitopes recognizable for the immune system. It will elicit new antibodies against those subdominant epitopes. And next vaccine breakthrough infection, you will have the same. You will have a boost effect on these subneutralizing epitopes, these subneutralizing antibodies. They will then be able, at this high concentration, remember, at this neutralizing concentration, to mask the newly discovered epitope, and they will therefore make it possible for the immune system to recognize epitopes that are even more conserved. So what I want to show with this is that this immune refocusing is driven by antibodies of lower and lower affinity. So you could say, wow, that is great, because now we have shifted from this antibody-mediated immune refocusing to a cell-mediated refocusing, so to say, mediated by the CTLs. And as the cell-mediated responses, only antibody responses, by virtue of these high titers that mask epitopes, can generate immune refocusing. So once you have as predominant effector of infection mitigation the CTLs, you're no longer going to induce immune refocusing. So you could say, wow, this is fantastic, because no, I don't have immune refocusing anymore. I'm no longer having to have immune escape. We're going to anti-pandemic. Unfortunately, it's not the case, because what this means is when you have this dramatic stimulation of CTL response. Why I'm saying dramatic stimulation? Because first of all, due to these large aggregates, the antigen-presenting cells are overwhelmed with this stuff and are busy all the time to take up these larger aggregates. And even if other, antigens, for example, would be internalized, any antigen-presenting cell that has taken up this universal epitope will be so strongly stimulated that it will, so to say, ignore other peptides like T helper peptides. And that is also the reason, it has very pragmatic and practical consequences, why none of the updated vaccines will still work, because the antigen-presenting cells are so busy taking up these larger aggregates. Once the antigen-presenting cell has picked up the universal epitope, it will be so strongly stimulated that it will no longer concentrate on stimulating T helper peptides. And
Is this where this slide comes in? Two
well,
dogs
this
fight
slide
for a bone.
then comes, in fact, in at the very end, because I need to conclude this. If you just, Philip, could show the slide. Which one? Let me see.
Don't worry, I can show you. You tell me. Is it this slide here? Just look on.
No, it's the slide before, in fact. Yeah. So what I was saying is that if all these neutralizing antibodies, remember, every single time you have vaccine breakthrough infection, you boost them. But this boost is only possible, the recall of these antibodies is only possible, of course, if you can recall the T helper memory cells that provide assistance to the boosting effect of these antibodies. So if this boosting effect does no longer take place, or it is diminishing because the antigen-presenting cells are prioritizing the CTL stimulation over the T helper peptide stimulation, then you will see a decline in those antibodies, and the reboosting will be much weaker. So when the concentration diminishes, you will move the graph number 5, Philip. You will move this graph, of course, more to the right. You see, this is depending on the concentration. This is diminishing concentration or diminishing affinity. You will more and more move this to the right-hand side, which means that you have even more CTL stimulation, that you have even less stimulation of T helper cells. But the problem is that when these new variants are coming in contact now with the boosted individuals, that these antibodies, these are the infection-enhancing antibodies, will have completely disappeared, so to say, because the whole thing will be shifted to the right. And here comes the thing. The diminished concentration of these infection-enhancing antibodies is a disaster, because these infection-enhancing antibodies are also responsible for inhibiting the virulence of the virus. And there are publications, at least in vitro, that show very clearly that antibodies that bind with weak affinity to this conserved antigenic site within the N-terminal domain of spike can block trans-infection. They can block the transfer from the virus, from a dendritic cell that migrates to the lung or other organs, to the susceptible cells in that organ. And that is the way how they inhibit virulence. The more you are now shifting to the CTL mediated mitigation of infection, the more you're going to diminish the concentration of this infection enhancing or virulence inhibiting antibodies. So now you are going to put suboptimal immune pressure on viral virulence. And that
So,
is what's going on. And that is what is highly, highly alarming. And, we have seen this with Omicron, that, we had, for example, there, the harbinger was Delta. Delta all of a sudden became almost like too virulent. The virus didn't want to allow this because more virulence means that you kill more people, that you have less opportunity to reproduce. Hence, it came with a spectacular change in the receptor binding domain so that it now could become more infectious again. Now the harbinger is the JN.1, because this one is telling us that, in fact, there is tremendous immune pressure on the infection enhancing or virulence inhibiting site within the N-terminal domain. What is similar between those two scenarios is that both with regard to Omicron, immune pressure was put on a very small domain within spike protein, right? The receptor binding domain. Here, we are putting immune pressure on a very small domain within the N-terminal domain. The antigenic site is conserved, is a very small one, and we are putting all the immune pressure. It's not diluted, it's all going there. So I really expect, Philip, this to happen now very, very soon. And
so let me just clip something here that
yes,
I've wanted. You've had here in your paper, and I've just highlighted it here. You've emphasized on multiple occasions healthy unvaccinated individuals will not be affected by this new variant. What exactly do you mean by that?
well, since a long time, Philip, the unvaccinated, they have shifted towards their innate immune system, which is normally very rudimentary. That is why it is legitimately called the first line of immune defense, already suggesting that when it becomes serious, you're going to need the special forces like the T cells and the B cells, right? But of course, when you train this innate immunity, then of course it can become much, much stronger. And of course, we know as well the unvaccinated as the vaccinated could no longer rely on their adaptive immune system. So the problem is that the vaccinees, because of the vaccine breakthrough infection, and the high antibody titers that resulted from this, that they could not train their innate immune system. That is a huge, huge problem. So they ended up with a corrupted adaptive immune system, a system that is still healthy, if you like, but it's doing completely the wrong thing. And so it is becoming useless because the last defense they have is this protection against virulence. But as I was saying, as I was showing, the virulence inhibiting antibodies are already decreasing, and this will put, of course, immune pressure on viral virulence. So it is becoming useless, and their innate immunity didn't get trained either, because the vaccine breakthrough infections that drove immune refocusing have been bypassing, have been sidelining training of the innate immune system. So that is of course extremely worrisome. It's not the case in the unvaccinated. And the unvaccinated have been trained more and more by more infectious variants. And of course, if now the virus shift to virulence in the context of a vaccinated immune system, then it will most likely pay a fitness cost, A fitness cost means that in compensation, it will become less infectious. And therefore, I'm predicting that when this new variant emerges, that in contrast to what is happening right now, that some of the unvaccinated still have some mild or moderate infection, but not severe, that they will become completely that the infection will be completely asymptomatic even. So that is what I am clearly predicting.
So one of the things that I've been saying, and you can correct me if I'm wrong, is one of the concerns I have is that there is so much circulation of virus that, in my view, anytime the virus breaks that mucosal barrier, whether you are vaccinated or unvaccinated, that seems to be a risk, the recurring infection. And so, in an environment where you have a highly vaccinated community, unable to control the viral circulation, it means that that unvaccinated cohort may be continuously exposed to the virus, where it just takes one slip, meaning that if your immune system, it fluctuates, it's not exactly the same all the time, then you can have that infection. And so this is why I say that there is a risk to everyone in this kind of situation. Thoughts on that?
Yeah, I completely disagree with this. That is exactly the impact of the epigenetic changes on the functionality of innate immune cells. And I always compare this literally with physical training. You lift 20 kilograms, you train, you can lift 30 kilograms. In the end, you train 16, 80, 90 kilograms, and you can only manage this thanks to the fact that there is a challenge, thanks to the fact that you try this 70 kilograms, for example. We have no chance with our innate immune system because the more infectious variants are circulating. But you get trained, and if all of a sudden now somebody says you have to wait to lift this weight, but it's not the 80 kilograms that the maximum that you could lift, but it's only 70 kilograms, then you won't have any problem. When you lift always some higher weight, you can have some muscle soreness, etc. the next day. That is why the price the unvaccinated have been paying is that indeed they have also got some mild, some moderate disease. But all in all, I'm always saying people who are in good health and got infected by these more infectious variants, none of them should have developed severe disease. At most, moderate, mostly even mild. So we are prepared for this. And remember, the innate immunity is non-variant specific. So it doesn't discriminate between different types of variants, different mutations, etc. The only thing that counts for the cell-based innate immune system is the level of infectiousness. Well, if the innate immune system is trained to deal with a higher level of infectiousness, then there is absolutely no worry for somebody who has gone through that process.
Yeah. So listen, Gert, as I'm pulling up this slide here because I think this is important as we come to try and tie this all together. Can you explain what you meant with this image?
Yeah, well, that is has been, of course, my observation all along. That the whole what I'm seeing is that the whole COVID crisis is now very much focused on a fight between two parties, and the stakeholders of the campaigns, that are still, as you were just saying, Philip, trying to convince people to continue vaccination and to take the boosters, although I'm saying the boosters won't have any effect anymore, but they are still putting the pressure wherever they can. And then there is the underdogs. We probably many of us who have been fighting against this, but we don't have the same strength, of course, because we don't have this huge lobby of media, of the vaccine industry and policymakers behind us. So we are the underdogs. And right now, what we are seeing is that there is a lot of debate, and we are gaining, some pressure, and there is a lot of lawsuits going on. It's all very legitimate. Yeah, you don't hear me saying that it's not legitimate, and you hear all these discussions now about the DNA contamination in the vaccines and the ribosomal frame shifting, and all the and of course the adverse events and excess deaths and plenty of discussion. But what I'm seeing is that nobody is in fact worried about the evolution of the virus. And what I'm saying is that two dogs are fighting for a bone. And I'm not saying that this fight, especially of the underdogs, is not legitimate. I'm just saying it's distracting us from the major issue. Frankly speaking, all the adverse events and the side effects and the contaminations and you name it. I mean, I'm taking this very, very seriously. But nevertheless, and I always say this from the very beginning, this is peanuts compared to what will happen if the evolution that I'm talking about and that I'm convinced of that is being prepared right now is going to occur. And that is the virus who is running away with the bone, not because, the dog is stronger, but is fast. And that is what we are seeing. The speed with which JN.1, for example, is now spreading, and what it means in terms of the immune pressure now on virulence inhibiting antibodies, the last tool that vaccinees have to protect themselves from severe disease. It's not the T cells. Those who are pretending this should go on my website. There are at least 10 or 20 articles to debunk this. The T cells, they can produce cytokines, of course, they can mitigate the infection, but they cannot cut the transmission. And because otherwise we would have had, since quite a long time, we would have seen this, because if you would have memory T cells that can kill virus-infected cells, it would all solve the problem. We don't have this. And nobody has ever shown that either the vaccine or the natural infection is inducing memory CTLs. I mean, if natural infection would do that, we would not have, this type of infection anymore. Because if you would have memory cells, you get infected, it would immediately kill the virus-infected cells and the virus would be eradicated. It's as easy as that. So that is what I mean by this slide.
So we're going to have to tie it together now, Geert. And here is the reality. We have a lot of people who are concerned and who are worried about what is going to happen next. And as I know, it's very difficult to predict timing. But what I am seeing as I think about it clinically and I look at what the trends are, the excess deaths in the UK and so on, I am anticipating this to just exponentially rise. Are we talking about, a few hundreds of thousands, or is this millions of people across the world who are going to be very significantly affected? And I'm talking about mortality here. I'm not talking about just people getting sick. What are your thoughts?
Well, my thoughts are definitely that the losses will be tremendous. And I hate to say this, especially now, just before Christmas. I hate myself for saying this, but somebody must tell what is going on right now. And I mean, I can get an excuse for missing the timeline, but I'm not an unscrupulous person. I cannot get excused for conveying a message that is not true. I cannot be excused for that. I must be excused for the fact that I missed the timeline. This was because of the immune refocusing. Remember, the immune refocusing drives immune escape, but it allows the immune system to come back a little bit, to recover a little bit. And that is at the advantage of the virus, because in this way, it can prolong the period of viral spread and therefore survival. But it means that, in fact, it all progressed relatively slowly. But you heard me saying, very importantly, this game is over. There is no immune refocusing anymore, because the infection mitigating effect is now triggered by CTL responses, no longer by the antibody responses. So there is no recovery from the immune of the immune system. That is one thing. The other thing is that the immune pressure on this conserved antigenic site within the N-terminal domain, it's a very small, just like the receptor binding, it's a very small domain. So there is no immune refocusing anymore. This thing now goes forward, goes very fast, and all the immune pressure is now on this small domain. So the transformation into a variant that will prevent these infection or these virulence inhibiting antibodies still from attaching to this site, this is for me very imminent. And I'm not talking about months. I'm talking about days and weeks. And how many people, luckily enough, there is always, biology has always a gray zone. And it is very clear that people who have been exposed prior to the vaccination have better chances to survive than those who had no exposure, have been vaccinated right away, even multiple times. But so there is definitely a gray zone. It will be a continuum from people who have asymptomatic infection, primarily the unvaccinated, to people who die suddenly from very severe disease within no time. There will be, of course, a whole range of intermediate cases, depending on, of course, the number of vaccinations, the time point of vaccination, whether you have been part of a population that was vaccinated very, very aggressively within a few months, where, of course, immune pressure is much, much higher. A number of factors will, of course, play to generate a kind of gray zone. But let me be very, very clear. The damage will be enormous. And as I was saying, I can be excused for missing the timeline. I cannot be excused for conveying a message that is completely wrong. But somebody has to do it. And I don't like to do this, not at all. I have tears in my eyes when I say this, but it is reality. It is reality. We have come to the point where JN.1 is telling us it's the harbinger, of a new variant that will dramatically change the scene, just like Omicron did. Luckily enough, for Omicron, it was just about the infectiousness. For the new one, it will be about the virulence. And so for me, it's very clear, recess is over, playtime is over. And for me, all other discussions are at this point obsolete. This is the one that we don't control and that is evolving in an extremely dramatic way. And our public health authorities are doing as if nothing were, just observing, looking where this is going, saying we have endemicity, we have herd immunity, we will need to live with the virus, and we will do yearly vaccination. It is, I'm sorry to say this, I'm weighing my words, this is complete bullshit. It's dangerous bullshit what they are, the kind of messages they are spreading. And I'm also completely pissed off with all the scientists who are blindly following this narrative. And as I was saying, they should do their ELISAs on these antibodies, for example, to see that these are not truly neutralizing antibodies. And we should look at the titers. They should do these titers after like several weeks. Already some publications are showing that the neutralizing effect you were showing, Philip, that a lot of these these neutralizing antibodies against a lot of these new variants were much lower. If you now look at the neutralizing titers against JN.1 and the so-called neutralizing titers, they are extremely low. So it is very, very clearly showing that, you know, the infection mitigating effect, we can no longer rely on the antibodies. It's now the CTLs. Those guys have no mercy because there is no immune refocusing involved anymore. They spread, and the virus spread, of course, because it is under this infection mitigating pressure. It has become GN1 very, very infectious. And, you know, to prove that I am right, I will give you the answers. I've put this on paper to 5 questions. First of all, will the chain of more and more infectious variants stop? My answer is yes. People can verify this. We will not have yet another simply more infectious variant that is going to displace and outpace GN1. So that is one very clear answer. Second question, will a new variant, a new completely different variant emerge in highly vaccinated countries, completely new? So that is the one that is going to cause virulence in highly vaccinated populations. My answer is yes. Will the rate of mortality and morbidity start to exponentially increase? Now it's still maybe linear, I don't know. Will it exponentially increase? My answer is yes. People can look at this, and this increase in mortality and morbidity rate will be in the vaccinated, not in the unvaccinated. But it will be difficult, of course, to have those figures. Will the unvaccinated in good health be affected? No, that is what we just discussed. Will Africa be affected? The answer is also no. So people can verify the answers to those questions. It's not about me being right or wrong. It's about the disastrous situation that we are in, and where I have to recommend all people who are thoroughly vaccinated to take antivirals. I would not wait, because within no time you will see how these curves will start to grow exponentially. Take this antivirus. I tell you one thing: the ivermectin, hydroxychloroquine, have been forbidden. We were not allowed to take this. Doctors were not allowed to prescribe this. I will tell you that there will come mandates where health authorities will oblige people to take it, right? That is how the situation will be completely inverted. And that is always what happens if you're trying to lie and to hide the truth. When this kind of crimes are committed at small scale, you can hide them. But this has now done at such a large scale. Nobody will be able to hide this. That is 200% my conviction. Sorry, Philip, for taking so much time.
No, this is it, I usually like to just listen and reflect on what you're saying, and I think you're absolutely right. I think even now there may still be a window of opportunity to suppress the viral spread if they did exactly as you said. I think they just either they don't understand how it could help, or they don't want to understand how it could help. But either way, the history is going to show that by not trying at this point, those who supported that are not going to be on the right side of history. At this point, anything that could potentially work should be used. I agree with you, Geert, that we are facing a monumental crisis. I don't know if it's already too late, but I think that to do absolutely nothing is horrific. We should never get into a situation where we do nothing. Final word on this here, Geert. When you have eliminated the impossible, whatever remains, however improbable, must be the truth. What do you mean by that?
Well, you know, Philip, when I hear myself, you know, sharing this, I'm thinking by myself, for God's sake, I mean, how would this be possible? I mean, this has never happened before. How all of a sudden mankind could be facing such a disaster. As a human being, I cannot accept this, right? I can only accept this as a scientist, but I cannot accept this as and instinctively, so, some voices tell me, here, this cannot be true. This cannot happen. There must be a way out. Something is going to happen to mitigate this, etc. But I can tell one thing is that I have done my homework. I have done it in a very thorough way, very profoundly. I have collected all these pieces of the puzzle and I've put them together. And therefore, when I was telling you what we are seeing right now with the surge in mortality and hospitalization rates and the type of the changes in the virus and the fulminant spread of the virus, etc. These are additional pieces that, because I have done my homework before, I can easily fit in. I can easily put those pieces in the right position. Those who have not been doing that homework and putting the piece of the puzzle together, but were only puzzled about the evolution of the whole thing, cannot do this. So I must say, I have ruled out everything else. And the likelihood that all these elements, you have seen elements of biophysics, you have seen elements of immunology, you have seen elements of virology, of vaccinology, come together in a way that it doesn't violate any of the rules of the laws of these disciplines, yeah, then, I mean, it cannot be otherwise. It cannot be otherwise than that is the truth. And again, if I were not 200% convinced, I would not dare to show my face here, right? That is the level of my conviction. And I can share with you that I will, with family and friends, I will sit together next week to see how we can prepare for this chaos that is going to come, but where health authorities, do as if nothing were, because JN.1 is not more virulent than the others, right? And it's like a volcanologist who is trying to predict an eruption of a volcano. If he would just look at the fissures and the cracks at the surface of the earth, I think the likelihood that they would be able to predict an eruption is very remote. What the right, volcanologists do is that they do all kinds of examinations, gas emissions, and change in magnetic fields, seismographic registration of earthquakes, etc., etc., and to see what is going on underneath the surface. Our health authorities and experts have only been looking at the surface, whereas the whole thing is under the surface. That is where the whole thing and where the lava is rising right now, right? So that is what I mean with is that I consider that I have ruled out everything, and that even if it is a very dire message, for me it cannot be anything else but the truth.
Thank you very much, Gert. Thank you very much to everyone who has been with us. It's been heavy science, and I'll have to go back through some of it. But I think what anybody who has listened to Gert knows is that he is speaking from the heart. He has a genuine conviction and a genuine concern for humanity, and he's willing to stand up and make his voice heard. That is a tremendous gift to the world, Gert. And no matter what happens next, I think that we all who have listened and have heard this are appreciative of what you have done. And may that continue. As I have always said, I don't mind you being wrong, Gert. I'd be happy to let people laugh at you because, wow, you said this and it was wrong. But if you are right, we are all going to face a very, very difficult time.
Mm.
Thank you to everyone.
Yeah. And thanks, Philip, for giving me the opportunity to share this, even though I realize it's not a pleasant message.
Wonderful. Thank you. Just stay with me, Gert. And thank you, everyone, for listening. Have a great evening.
Mm.